Good evening and thank you, Dr. Viraj, and thank you, the organizers. It's always a pleasure to speak in any meeting and to talk on a topic that I enjoy a lot. I am right now in AIG Hospitals, which is one of the centers for gastric oncology, and we do quite a bit of oncology. So this is my lecture, and yeah, I hope these slides are visible. Right. So what I'll be talking about today are the mutations that we are dealing with in GI cancer. I have a particular bug when anyone talks of NGS as loosely, because personally, what NGS is a lab technique. Let's be clear now. NGS is just a lab technique wherein you are doing a massively parallel high throughput sequencing. What we do is we take advantage of this miniaturization to engage in a massively parallel analysis and carry out millions of sequencing reactions simultaneously to look for a sequence. Right? This is what NGS stands for. It's next gen sequencing. So you can use it for anything. You can use it for testing for susceptibility genes, risk assessment, microRNAs, methylation, patient stratification, monitoring, and every other thing. What Dr. Viraj wants me to talk today, and what is the subject of my next 15 to 20 minutes talk, is actually this. When you start looking at particular sequences and you start interrogating specific genes, trying to find specific driver mutations or mutations that would be causing the cancer to grow. So it is essentially a type of comprehensive genomic paneling wherein we try to find driver mutations for a particular cancer. Now, there are these categories which are there. You have category 1, 2, 3, and depending on the pathogenicity, whether it is really a driver mutation or not, we need to take a decision on that. Now, I am not going to be spending much time on all those things today. I'll try to see where CGP is fitting into GI cancers. So, in GI cancers, we talk of esophagus, we talk of stomach, we talk of the intestine, the colorectal, pancreas, and biliary tract tumors, and the HCCs. These are broadly the large area of GI oncology. Now, when we talk of NGS and looking for particular mutations, either we can look for specific hotspots, or what is the general terminology when you say a CGP or a NGS? You do a broad-based pattern, wherein you essentially try to run, say, 150, 250, 300 genes and see if any odd mutation is present. It's what I would call fishing for mutations. Aside from this, of course, you do have certain tumor agnostic indications. So let me go one by one to all the different cancers and try to see where we are if we try to look for mutations. Gastric cancers. We have a patient who has just come today to me, who is a, say, 43-year-old lady with a large gastric mass and multiple lymph nodes and a few liver metastases. Conventionally, I know this patient is not going to do very well because gastric cancers have an overall survival anywhere between 1.5 to 2 years. That's being a bit optimistic, but that's what it is. Can I do something and find out rare mutations that I can target? That's the idea behind looking for these genetic mutations. Now, when the TCGA was done, we knew after all of that that stomach cancers can be genomically divided into 4 broad categories. You have the CIN group, you have the genomically stable group, the EBV positive group, and finally the MSI group. Now, as you can see, as you start ascending up from the antrum to the body, to the cardia, to the lower esophagus, the proportion of your chromosomal instability increases exponentially. In the lower stomach, you do have these other subgroups, but they are mainly confined to that. So your lower esophagus and G junction is mainly the CIN group. Beyond this, what are the trials and what are the mutations that we have found? Here, HER2 came with a big bang. We know that HER2 came with the TOGA trial where we found the median OS of 13.8 months. Unfortunately, that was it. Beyond that, you had the Jacob study, the Logic study, the Titan, and the Gatsby incorporating various drugs. You had lapatinib, you had the TDM1, first line, second line, everywhere. And unfortunately, when you look at the results, aside from this trastuzumab, where you're finding this good a response of around 2 years, 2.5 years, Everywhere else, it was either non-significant or inferior. And that's what it is. Your Gatsby showed TDM to be actually inferior to HER2. That put a bit of a dampener because you have a target, so-called a driver mutation, and still nothing works. Why do we find it like that? Well, there are plenty of theories, but the most important theory in GI cancers, in gastric cancer, is that there is a lot of genomic heterogeneity. So depending on what you are sampling, depending on which tumor you have sampled, which genes you are able to sample on your NGS, your response will depend on that. That is one reason why they say that nowadays we should look at the circulating tumor DNA and try to find multiple mutations. Can we actually use multiple drugs in that situation? And the answer is, well, we are still exploring. Beyond HER2/neu, what are the mutations that we have seen? The MET, which was seen in lung cancer again, and here, when they use a new drug, MET inhibitor called onartuzumab, non-significant. When you have the HGF, which is again one of the components of the MET pathway, again it was negative. Looking at the mTOR pathway, looking at the Fgfr pathway, looking at the VEGF pathway, all these pathways, whichever drug we used, it was a rather massive failure. So unfortunately, in gastric cancers, though the idea of doing the CGP is very appealing, we may not end up finding a very good mutation. Presently, what we are looking forward to is actually only the immunotherapy or the trastuzumab deruxtecan, which appears to be becoming like a savior in every case. That's about gastric cancers. What about biliary tract cancers? Now, biliary tract cancers again are a big group, subgroup, including gallbladder, cholangios, intrahepatic, extrahepatic cholangios. When you look at these survivals, unfortunately, the 5-year survivals in metastatic GI BTCs are close to 8 to 10% only. Now, there's a lot of excitement which came around when you discovered the precision medicine for biliary tract cancers. You had FGFR2 being present around 15 to 25%, IDH1 present in around 15 to 20%, a significant subset of HER2, BRAF, and then, of course, the NTRK and the other kind of markers. So, again, looking at it sounds very interesting. When you look at it one by one, let's go to the FGFR fusions and mutations. Now, FGFR fusions and mutations would be detected on an RNA NGS or a DNA NGS. You need to look for the fusions through the RNA. Now, different kind of studies have been done, multiple studies. This is just one of them, where they showed that cholangios with FGFR occurred in younger patients and had a more indolent course. And therefore, the idea was that maybe using FGFR targeted therapy, you would have a good impact. The drug which was used is pemigatinib. Now, pemigatinib, again, sounds interesting, but look at this response rate. Overall response rate 35%, duration of response 7.5 months, PFS 6.9 months. Other places 1.4 months FGF months only, and if you do not have this, there the PFS is 1.5 months. So overall, though pemigatinib has been given an accelerated approval, the fact remains that the drug is something interesting. It's probably good to be used, but it's not a panacea, definitely not like our lung cancer markers. What about IDH1 and IDH2? Now, these are intrahepatic, this dark colored, and light colored is extrahepatic cholangiomas. When you do an analysis of the different mutations, you find that IDH1 is almost exclusively seen only in intrahepatic cholangios, KRAS and TP53 more in the extrahepatic, and then this other small subgroups are seen in the, or mostly in the intrahepatic cholangiomas. So do we have drugs? Again, the drug which was used is ivosidenib, not available for us, of course, in IDH1 mutant chemotherapy refractory patients, not first line, second and beyond, randomized phase 3 study. And again, when they looked at the study, if you look at the numbers, well, not very exciting. You have ivosidenib being used in 124 versus placebo of 61 patients. Follow-up of only around 7 months. Improvement was certainly there, but that improvement is only coming for around 1.3 months. So we have 2.7 months versus 1.4 months. Hazard ratio fantastic, 0.37. P-value fantastic, but clinically 1.3 months. When they looked at the overall survival, Frankly, there was no overall survival benefit when you actually looked at the study, but then something known as an RFST kind of analysis, where you try to look for account for the crossover, that's when you started seeing a OS of around a couple of months. But as we do keep discussing, again, this is a mutation in search of a drug. Ivosidenib is certainly not as effective a drug as we would want. And again, our benchmark is always lung cancer. Certainly, BTCs, we do not have the same kind of responses. What about the other drugs like the dabrafenib, trametinib for BRAF testing? Again, small study, 33 patients, overall response rate 41%, slightly more respectable PFS of 7 months and an OS of 11 months. So this is a mutation where certainly if you find it, it will help. As my friend Dr. Viraj can attest, he had one paper which showed dual BRAF MEK inhibition, only 2 case reports, but still you get this, you are likely to get a good response. What about HER2/neu? Again, a mutation that we have been hearing forever and ever, but frankly, between the mutations and the amplifications, between neratinib, TDM1, other inhibitors, the results have not been as encouraging. I think we have to wait for the deruxtecan reports even in this setting. Needless to say, deruxtecan is not available. So for all us poor Indians who will do the mutation analysis, well, the results are not great lights. What about BRCA mutants? Now, BRCA is something that has come around a lot in the last 1 or 2 years, talking of different types of BRCA mutants. So again, when you look at the BRCA mutants and the wild types, you are having PDL1 positive in higher percent, in a reasonably high percentage, but MSI high, not too big. Again, right now, we do not have data on the PARP inhibitors here, but that's something that can be tried. What about pembrolizumab? Used in every cancer. 2 trials, median OS 7.4, PFS 2 months. Needless to say, really not that impressive. So when you have a patient with BTC, giving immuno might not really be a great option as well. A lot of other trials going on in combinations, but still response rates anywhere between 12 to 20%, pretty much a difficult cancer to treat. What about pancreatic cancers? Now, pancreatic cancers are unusual. You have 90% of them being actually only KRAS mutant. The KRAS wild type constitutes only 8 to 9 to 10%. When you look at the particular genes, G12C is the only thing we can target right now. Not in India, but at least we have a target. We have sotorasib there. Only 1.6%. The rest, G12D, G12V, R, and all the other codons put together will constitute more than 80 to 90%, and we do not have a target there yet. We are going there. In the next 2 to 3 years, we are expecting a whole raft of new KRAS inhibitors, but as of today, probably not. What about this 10% which is wild type? Remember, in lung, we talk of 2% ROS1, we talk of 2% others. What about here? So you have BRAF mutation, activating deletion, FGFR, RAF1, ALK, NRG, RET, MET, and this whole bunch. Among all of them, unless I get a MET fusion, or I get one of this BRAF, or I get an ALK, or one of this ERB2, honestly, not much that we can look for. That whole subset is 38% of the 10%. So in effect, today in my practice, if I want to order a pancreatic adenosia, I should be prepared for a mutation report in probably 3 to 5% of my patients only, where I can use a drug. I'm not being here to discourage people, but that seems to be the data that we have right now. Doesn't mean we should stop, but this we should be aware of the results for our patients. What about the POLO trial? Now remember, last year POLO came up in a big way. We spoke of germline BRCA mutated metastatic pancreatic and maintenance olaparib. This is germline, not somatic, not HRR. We are talking of germline BRCA. Again, initial results were very exciting. You saw PFS value. Unfortunately, when you look at the final results, the overall survival of hazard ratio 0.83 all over the place, non-significant. 19 versus 19.2 months. Yes, if you look at the PFS2, you start tending to get some benefit. You start looking at more fancier stuff, TFST, TSST, and so on, all these newer things that have been invented, and you find a benefit. But as they say, show me the money. If you have to put your hands up and say, yes, this is a targetable mutation, I am not sure I would agree with it. I would still test for germline BRCA, but my enthusiasm for a PARP inhibitor in pancreatic has certainly cooled down after these kind of results. Colorectal cancers, again, we end up looking for a lot of the mutations, but remember, our KRAS, NRAS, BRAF are more for helping us to know what not to do rather than actually knowing what to do. This is what we are definitely sure of in colorectal cancer. Left versus right. Beyond that, whatever we do, it's only in the second, third, and beyond lines. BRAF is one where we seem to have some benefit with the BRAF inhibitors, and definitely in second or third line, I would be happy to use it. KRAS 12GC, if we have it, yes, sotorasib is going to be effective there. HER2/neu, if we have, which I'll show you the data now. Beyond that, the only other place it works is MSI high. That was the keynote study. So this is the Destiny CRC trial, phase 2, confirmed overall from 45%. So this is where I would probably be interested. So if I have HER2, which I don't, probably HER2/neu mutations in CRC, I have a drug coming. Hopefully in a couple of years, we'll be available here. This seems to be one of the few things that can be responded. Basket and umbrella trials for GI cancers. Yes, it sounds very interesting. Look for all this. Unfortunately, it is most often like this, where the number of patients looking for those elusive targets are much lesser. If you go by the numbers, it's probably your denominator is very huge, but ultimately less than 10% of patients would get a proper targeted drug. So not a reason not to do it, but a reason to exercise caution. This is just one example, the Godzilla trial, which should be coming soon. It is looking at ctDNA and then trying to look for different drugs. And again, anyone who goes through this list, we do not have a lot of these drugs. So it's interesting to know and good to do, but often you will end up without having the drug to be given to the patient. What about this tissue agnostic approvals? So you have the tissue agnostic approval in MSI high and TMB high. This has been approved on the basis of a trial which included some 70-odd patients of 23 different cancer types. And FDA has approved it. I think FDA has come under the scanner for a very good reason in the last couple of years. What about gastrointestinal cancers? Looking at the MSI high, colorectal 10 to 12, gastric here, HCC hardly anything, pancreatic hardly anything, intrahepatic cholangios 10%, ampullary and gallbladder again not very high percentage. So again, it's good to test for, very good if your patient has such a report, but not really true for all our patients. I have deliberately not put HCC because the scene there is even more depressing. You really do not have any somatic mutation. So for me, still the summary would remain that NGS is a very promising method to look for somatic mutations, no doubt. CGP remains a good test and it's something we should look for patients. But the benefit in cancers ranges between anywhere to 4 to 10%. That is a figure we should remember.
Dr. Manshi, 2 minutes left.
Yeah, last summary slide. This is my summary slide. So gastric cancers, if you see, there have been few driver mutations found. Pancreatic cancers, 90% KRAS, only the other 10% you're going to find a mutation. For BTCs, actionable drugs are evolving. I would still be okay to test here. Colorectal, mostly well defined yet to BRAF, KRAS, BRAF, HER2/neu and PIK3. We can do a limited panel or we can go for a NGS. For HCC, at least at this point, I really would not jump the gun and do a CGP for everybody, but that's what it is. So with that, I thank the organizers. I have, I think, been a little bit depressing or sounding pessimistic. The fact remains that sometimes we are over-enthusiastic in prescribing these tests. We should be aware of what we are dealing with. We should be aware of the drugs that are available. And definitely, I may completely change my mind. There was a paper which showed that between 2018 to 20, from 1% in 2018, 5% patients started benefiting from CGP. So hopefully in India too, we shall soon reach that stage. So thank you, everybody.